So my name is Mohan Sunta. I'm President and CEO of the University of Maryland Medical Center. And on behalf of our entire organization and our health system, I want to say welcome to all of you to a day that we are very excited about. So first, let me start by recognizing some of our distinguished invited guests who are spending time with us this morning. Certainly, U.S. Representative Elijah Cummings, thank you very much for your time and energy to be here today as we celebrate what we believe is a significant advancement for the citizens of Baltimore. Madam Mayor, again, a longstanding advocate for our health system and a phenomenal partner. Thank you for coming today. President Perman, again, a partner from the University of Maryland, Baltimore, and we as the medical center view our partnership with UMB to be critical to everything that we do and the reason that we exist. So today, this morning, I want to say that we're excited to talk about a program that we really do believe is an example of the transformation in how we think about delivering health care to a community. Today, we're going to talk about and explain to you all the Mobile Integrated Health and Community Paramedicine Program. And so when we talk about programs like this, it is critical to understand that we believe that in the state of Maryland, we have moved further and faster than any other state in the country in trying to define the value associated with the delivery of health care. And that value ultimately comes down to the impact that we have on people's lives. And this example today that we're talking about, Mobile Integrated Health and the Community Paramedicine Program, is a tangible example of where the power of partnership can actually be brought to bear for the benefit of the citizens of our city. Today you will hear about how this program came about, and I'll ask you to keep in mind some key foundational tenets that help drive this. Partnership is key. You will hear about the partnership with the city. You will hear about our phenomenal partnership with the EMS system, the Baltimore City Fire Department. You will hear about the partnership that we have with the regulatory system in the state of Maryland that oversees reimbursements to health systems. All of these partners were critical to allow us to create the program that you're going to hear about today. We are in this transformation in how we think about the delivery of health care, and moving from hospital systems to health systems means taking on the responsibility of the health of our community beyond the walls of our organization. And so while we are always going to also be focused on the delivery of acute health care services, today represents an example of how we think about the entire continuum of health care delivery. And when you think about how we've come across the idea of these partnerships and the importance that they play, my hope is that you come away with the notion that the concept of innovation and the concepts of partnership and the concepts of healthcare delivery and recognizing our most vulnerable citizens and their needs that go beyond just the delivery of acute healthcare services within the walls of the hospital are all the principles that help drive us to what we are here today to talk about. So there is no question that many of these partnerships are critical. I want to make sure I call out very specifically the Healthcare Cost Review Commission, the HSCRC, was a valuable partner in believing that this concept could be brought to bear and actually demonstrate tangible benefit to the citizens of Baltimore. They have been, again, they were the folks who stepped up and believed in our organization, believed in the partnerships we formed, and were willing to stand behind the test of this concept. There's no question that the medical center has enjoyed a storied relationship with MIMS, the emergency medical system that is, again, unique in the state of Maryland. And again, we definitely leaned on that partnership as we thought about the innovations that you're going to hear about today. And then the support of critical stakeholders in our organization. No question, Madam Mayor, the City of Baltimore has been a phenomenal partner in helping us navigate how we think about the delivery of healthcare outside the walls of our hospital, and helping us identify and address the most critical needs of the citizens of Baltimore. And so with that, again, I want to say on behalf of our entire organization, welcome. And with this, I'd like to invite U.S. Representative Elijah Cummings to the podium. And I will tell you that I've had the pleasure of meeting Representative Cummings and speaking with him many times. And the overwhelming message I get from him over and over again is the impact and power of passion. And so my hope is that today, when you think about his words and the words of others, you will hear a demonstration of the passion we have for this type of initiative. Representative Cummings.
Thank you. Thank you. Morning, everyone.
Good morning.
Please do a little bit better than that. Good morning.
Good morning.
It is certainly my honor and my privilege to be here this morning. And to Mr. President Sunther, I want to thank you for your leadership. And I want to thank the hospital for all it's doing in the medical system. I want to thank our mayor. I've said many times that she is a woman who truly believes in being effective and efficient and making sure that she reaches people where they are. So often what happens in our country is that so many people are so busy doing their own thing that they never come together. They talk about problems, but end up not doing a damn thing. But I'm so glad we have a mayor who gets up every morning and says, you know what? I'm going to make a difference in somebody's life. And when I think about this program, President Perman, this is when I got the invitation to come here. The State of the Union is tonight. Amen. But I said I really want to be here because I have learned how important it is to reach people where they are. You really do. After spending 6 months in the hospital, and the mayor's heard me tell this story, when I was about to get out of I'd only been there a month then, a lady comes up to me and says, a fellow patient who had been in there 3 weeks, she comes up to me and she says, Elijah, I'm getting out today. And I said, oh, Miss Murray, that's so wonderful. And she says, and then she started crying. I said, why are you crying? She said, when I came, they had to treat me. They had to treat me. But she said, so I got the treatment, but I can't afford the cure. Oh, you need to tweak that.
Yes.
That's what this is all about. Another thing that happened to me in the hospital is I had a chance to, Madam Mayor, to talk to a lot of African-American men. Many of them had not gotten checkups over years. I mean, like 30 years. I mean, and now here they were. They came in for one thing and discovered they had a whole lot of other things, a whole lot of other problems, and in some instances, it was too late. This is about saving lives. That's what's so wonderful about it. And it's practical. It makes sense. So often we find in our country, we know the things that make sense, but we can't bring the people together to do them. And so that's why when you talked about all the parties coming together to make this happen, that's why this is so significant. Innovation. We are taking innovative steps to use the technology that we have available to us to make a difference in people's lives. And again, we are being effective and efficient. I'm hoping that this program will be a model for the nation. One of the things I love about our mayor is that she and I agree that we want the things that we do not just to be for us. We want to set a standard for the nation. And when you can bring care to people, 'cause you know what? Because they ain't gonna come to you. A lot of the folks will not come to you. And let me put a commercial in right real quick for women. Y'all listen? The research has shown that most of us men get care because of women in our lives. Encouraging us to do the right thing, encouraging us to get the checkup, encouraging us not to look at that chest pain as indigestion. It might be a heart attack. Those kinds of things are very, very significant. And so, again, I think this is so important to Dr. McCosey and Chief Ford and all of our other partners and everybody involved here. Thank you. And so what have you done? What are you doing? Let's break it down to make it real personal. You're going to make it possible for somebody to be able to go to their daughter's wedding. You're going to make it possible for somebody to avoid a stroke. You're going to help somebody be able to deal with their high blood pressure so that they don't have to be sitting and getting blood cleaned. Come on now. All of those things go to the quality of life. And I cannot help, as I come here, I want to thank this hospital for taking good care of my mother. My mother had a stroke 3 years ago. She died, well, as of today, she died a year ago today. And I will never forget this hospital. First of all, I was born here, and my 6 brothers and sisters were born here. But I will never forget when, Madam Mayor, when my mother was, she came here right after stroke. They were giving her physical therapy. And I'll never forget the nurses and the physical therapists was working with her, trying to get her to just lift her arm. Just lift her arm, Doc. So she's sitting in the chair. They didn't know I was in the room. And she's trying to lift her arm. And she couldn't get it up. You know, she's sitting in the chair, right? Her whole left side was paralyzed. And so then she kept holding her arm up underneath, raised it a little bit higher. Said, no, Miss Ruth, you just keep your arm up, but I'm going to let go, and then I want you to, to keep it up. So she put it up again, and my mother's arm my mother doesn't even know I'm there. I'm sitting in the corner of the room. The next thing you know, she said, I'm going to do it one more time. She said, I'm going to do it one more time. And she said, I know you can do this. I know you can do it. And so she lifted it up again, and my mother's, next thing you know, Madam Mayor, my mother's hand kept going up. She let it go, and the hand kept going up. And she came up, and she came up like this, and she said, I said, whoa. And then she came back, trying to show off. Did it again. But then the moment came, and this is what this hospital and this system is all about. The moment came when she had done that. The therapist started crying. You would have thought she was at some funeral. And so I had to ask, I said, why are you crying? She said, because if you've ever worked with a stroke patient, those kind of things are very, very significant. And she said, by doing what she did, she was saying thank you. She said, I live for those moments. She said, this will make my whole year. But what is that about, Chief? I mean, that's about passion. That's about people who care and give about people. And so I'm so excited about this. And I want to thank people for coming together, making it happen. Because you know what? We've got one life to live. This is no dress rehearsal, and this is the life. And we've got to make the very, very, very best of it. Madam Mayor, you keep on doing what you're doing. Keep on doing it, because you're touching generations yet unborn. And will you ever be thanked? I don't know. Will your name ever appear in some glowing article about what you did in working with all these folks to make things happen. I don't know. But the fact is that you will have touched so many people. Just your compassion and your passion, but more importantly, your ability to get things done. Thank you very much.
Thank you very much, Congressman Cummings. At this time, I'd invite Madam Mayor Catherine Pugh to come to the podium. Again, Madam Mayor has been a phenomenal partner, not just to our medical center, to our entire health system. She has been a huge advocate for us for many years, and we so greatly appreciate all that you do for us and for our city.
Thank you. Thank you, Congressman, and thank you all for being gathered here. And I'm sitting here smiling at Dr. Cozy because he was reminding me that it was 2 years and probably almost 2.5 months right before I got sworn in, and I was here, and we were talking about doing this, and I had such a big smile on my face because one of the things that people will know is that I believe in mobility. I believe in taking services to people. And I know I'd shared with many who serve on the board of University of Maryland Medical Systems about my desire to create not just this kind of medical unit, but the unit that we created, where I raised over $500,000 to create a mobile unit to go out to people in neighborhoods and communities to get them jobs. Because just like you said, even with healthcare, you know, so many people standing on the corners of our streets won't come to you. We have to go to them. And here's what happens with this. And again, Chief Ford, Dr. Perman, Dr. Sumter, David McCorsey, thank you. Thank you, because I don't know if everybody realizes how many calls we get through the 911 just for folks who are asking for emergency services. 32% of the calls are for non-emergencies. This city has 620,000 people. Last year in 2017, we received 154,621 calls that resulted in more than 100,000 patients being transported to emergency rooms. And that's because people don't have the health care that they should, not enrolled into health care programs, use emergency rooms as though they're their own personal doctors. Mobile integrated health care, community paramedics. This new program will dramatically change the way we interact and connect with our communities. And just like the Congressman said, you know, this is another way of saving lives. And it is also a way of directing folks to the care that they really need. When we have these kind of public-private partnerships, and that's what it's all about, because the city can't do this work by themselves, the hospital can't do it by itself. It's how we're connecting with our fire department, with our paramedics, and making sure that we're providing the very best of services for all of us. This will transform the way we provide services, but it also is a proactive way of addressing these issues. The beauty of a mobile integrated healthcare environment is that it begins with a community needs assessment. And it's also an opportunity for us to utilize some of the technology that is out there. When I think about telemedicine and all the other ways that we can provide people with health care without them having to run into emergency rooms, that we're directing people to services that they need. This is a way to help people in their homes, in their neighborhoods, in their communities, but more importantly, to help us integrate health in a way that we believe is transformative. We also do believe that we are creating a system that others will follow, because they'll realize the impact of this. And just like you said, Congressman, every time we do something, we think about our city, we think about our community, but we think about our state and the nation. We believe that the things that we're doing, whether people see it or not, are very transformative. Congressman, I think about opportunity zones that we talked about almost a year or so ago. And yet Baltimore City, because we're 1/3 of the state's opportunity zones. Because when I came back from the U.S. Conference of Mayors, I said, we must get on top of this. We are the first city in the nation to get an Opportunity Zone grant. And I don't think you've read about that. But this kind of activity, what we're doing here, this is transformative. This is nation changing. This is state changing. And this is city changing. So thank you all. Thank you for the work that you're doing, but more importantly, for the work that you will do, the lives that you will save, and the lives you will transform. Thank you so much.
So I'd like to invite a friend and colleague to the podium next. It's now been a few years back that Dr. Marcosi had this idea, and he actually partnered with somebody. I see him in the audience here, but somebody who deserves a lot of credit for us being here today is Keith Persinger. And Keith is back here. He's now with the medical system. At the time, Keith was here at the medical center, and he and Dr. Marcosi sat in a room together, and they discussed the opportunity around mobile integrated health and why we thought it could deliver on our commitment to delivering value in the healthcare model in the state of Maryland and here at the medical center specifically. And so Dr. Marcosi was dogged in his passion about this and was unrelenting in terms of his desire to see this to fruition. And having come to us at the medical system, medical center, and the School of Medicine from time that he had spent in the federal government and as a member of our military, Dr. Marcosi came with, I think, a realistic view of the challenges that were in front of us to make this happen, but he was undeterred in his commitment to see this through. So, Dr. Marcosi, I invite you to the podium to say a few words.
Good morning. Thank you, Dr. Sunta. Distinguished guests and colleagues, I'm excited to speak to you today about the two new mobile integrated health programs that we think will improve the health of West Baltimore citizens and be a scalable model for our city and our state. Launched through novel public-private partnerships, these initiatives both began last year. The first is named Transitional Health Support. The other and second program is named Minor Definitive Care Now. I'll discuss in greater detail these programs and present some of our preliminary data. Before I do so, my shoulder-to-shoulder partner in this initiative, EMS Chief Mark Fletcher, and I would like to thank and recognize the Health Services Cost Review Commission and the Maryland Institute for Emergency Medical Services Systems for their strong support in making this project a reality. Additionally, we appreciate the advocacy and proactive leadership of Madam Mayor, Chief Ford, President Persinger, President Perman. I just got you a new title, Keith. Congratulations. Dean Reese and all the UMB deans who have been very supportive in this effort. Dr. Brian Brown, my chairman of emergency medicine, and Mr. Keith Persinger, as they are helping find solutions to the health challenges of our city. The mobile integrated health programs we will discuss today are designed to reduce health disparities and assist individuals live healthier lives, just as the congressman said. Focusing on two areas of intervention, we ventured into two different projects. The first is around pre-hospital health care. The second is around post-hospital health maintenance. As an emergency physician, I see firsthand the challenges West Baltimore citizens face to stay healthy. I also see when, despite their best efforts, they become ill or injured. Social and economic factors and the lack of a sufficient primary care infrastructure contribute to a high rate of healthcare utilization, and as you heard from the mayor, high EMS services responses. A person's health is defined by many influences, illustrated well on this slide. Interestingly, healthcare contributes 10% of a person's health, while social and behavioral issues contribute much more. Understanding this, we developed impactful programs to address as many of these factors as we could. Our first mobile integrated healthcare transitional health support, or for acronyms THS, began in 2018. The focus of THS is to help patients transition safely after their hospitalization to their home. Patients thought to have significant health barriers at the University of Maryland Medical Center's hospitals are invited to participate while they're admitted. After discharge, a THS field team evaluates this patient in their homes. This then team, which is staffed by community paramedics and nurses from Baltimore City Fire Department, assess the patient's needs, develop a plan to monitor, and then support their health for the next 30 days. Backing up this team in the field is a significant operations center staffed by community health workers, social workers, pharmacists, physicians, nursing, and they help ensure that the patient's health is maintained and the health challenges we identify are addressed for those next 30 days. There are many other innovative aspects of this program that are state-of-the-art. One example is the use of telemedicine, which provides instant video connectivity between patients and our providers. We continuously analyze data from our program to improve. For instance, we now know better and we understand the health challenges of our patients in West Baltimore. These challenges include, and are illustrated on this slide, getting and taking medications, coordinating care between providers, getting to appointments, and obtaining food. Our program is doing its best to understand the impact on our patients. On this slide, we actually compared healthcare utilization 1 month prior to our program and 1 month after enrollment in THS. After enrollment, hospital use decreased and outpatient use increased, suggesting an improved linkage to primary care and community resources. Another benefit we are starting to see is the THS patients return to the hospital less often than similar patients who are not enrolled. In fact, from August 2018, we have seen a 21% decrease in readmissions from THS patients. To have a successful program, it has to be rooted in patient satisfaction. And our scores presently, since the beginning of this program, are 9.7 out of 10. Let me pivot now to the second program we've initiated in West Baltimore. And that's the Minor Definitive Care Now project, which began in October of 2018. This program augments routine Baltimore City EMS services. The Minor Definitive Care Now team, which is a community paramedic and a physician or nurse practitioner, provides care to patients with low acuity conditions on scene, avoiding ambulance transport and the need to wait in emergency departments for evaluation. Let's approach this from a patient's perspective. Mrs. V was on a city bus when it stopped short, causing her to fall to the ground. 911 was called to transport her to the hospital. Our Minor Definitive Care Now team arrived and offered her on-scene treatment, to which she agreed. Mrs. V, a diabetic, had minor injuries and was given a prescription for her pain and information to help her manage her injuries. During her evaluation, interestingly, it was noted that she had an elevated blood sugar. And from the scene, we contacted her primary care physician and got her a same-day appointment to potentially adjust her medications. Thus far, we have provided on-scene treatment for a variety of low acuity conditions, including digestive, musculoskeletal, and skin conditions. With a focus on quality, since its launch, no Minor Definitive Care Now patients have returned to an emergency department within 72 hours. Preliminary data also suggests that when Minor Definitive Care Now treats a patient, the ambulance is available to go back in service 20 minutes faster. Our patient satisfaction scores for this program are 9.5 out of 10. These innovative delivery models support health, not just deliver health care. Our aim is to help those who need it, when they need it, where they need it. These programs create a win-win for our patients, the fire department, hospitals, and the city of Baltimore, and even the state of Maryland. Thank you for your time, and we look forward to taking your questions at the end. And now, I'd like to introduce one of the visionaries for this program and a true leader for the fire department in our city, Baltimore City Fire Chief Niles Ford.
Good morning. Good morning. Madam Mayor, thank you so much for your support in this program. We spoke about it early on, and you said, first of all, you were going to be a strong advocate. You have been. A strong lobbyist. You have been. And at times, a consultant. So I appreciate that. Congressman Cummings, thank you so much for all that you do for the community and your passion and your vision, quite frankly. Hospital leadership, thank you for being there. Thank you for, we met about this program approximately 4 years ago initially. And had some follow-up meetings thereafter. And thank you so much for your support in this program. Lastly, and probably greatly important to me, the members of Baltimore City Fire Department, the individuals that are here, as well as the individuals out in the field that are making it happen every day. I am thankful for what they do and blessed to be considered their leader. I have been in the fire service for over 27 years, been a paramedic, had a lot of jobs. I tell my folks in recruit school, and I joke with them, I've done just about everything you can imagine doing. I've even been a band director. I worked for Chuck E. Cheese, and I was Chucky. But I will tell you this much. The reason why we get into this business is to take care of people. Simply to try to make a difference in people's lives, simply to try to make their lives better because we were there. And when I was a paramedic, one of the toughest things I had to deal with was I felt like we were part of an assembly line where we just grabbed the patients, moved them to the hospital, went back in service. Grabbed the patient, moved them to the hospital, went back in service. Went back to the same patient, grabbed that patient, took them to the hospital. It felt like we weren't making a significant difference. Where we are now and the direction we're looking in now gives us an opportunity to make a difference out in the field. I have members in my department who are nurses. I have members that are paramedics, and Chief Fletcher, who has been spearheaded this program, who was drum major of this program. When he put the call out for members to join and be a part of it, we had a deluge of membership when we told them what we wanted to do. People who are nurses and paramedics as well. And in their last training, I visited a couple of their trainings because they require extra training to be a part of this program. And I just want to tell you one little short spigot of what somebody said. They said, we went out to the patient's residence, and this is early on in the program, and we sat with them. The patient had a garbage bag full of medication, had a history of running back and forth to the hospital, had just gotten out, and after, I'm not going to tell you specifically about what they said the patient's needs were, but I want to tell you the last thing that they said to me. We fixed her. We fixed her. That sounds simple to you all, but to leave there with the satiety of knowing that you took care of somebody's needs and they did not have to go to the hospital because you were there, and they had a better quality of life because you were exposed to them. I don't know if I could put it in words. I wish I would have been in that position. So I'm so happy and I'm so thankful to you all. I'm so happy to be here and be a part of it. Thank you so much, University of Maryland Hospital. Thank you so much, Mayor. Our goal is, right now, we're just in West Baltimore, but we're nipping at the bud right now to try to move further and move throughout the city and make this systemic. Thank you all so much for your time.
Now I'd like to call to the podium President of UMB, Dr. Perman.
Thank you, David. It's really a privilege for me to be here and help unveil this project. Congressman Cummings, Madam Mayor, thank you for appreciating, championing this vital project. Can't do it without your leadership. And of course, Dr. Santha, Chief Ford, Dr. Marcosi, and all who've made this a reality. Thank you all for your leadership, your contribution. As noted by our distinguished speakers, this is what happens when people partner. They know it's important, and they make it happy. They make it happen, and they make it a happy event. Why was the university writ large so privileged to contribute? As you've heard, the university's pharmacists, physicians, nurses, social workers are part of the operations center, offering vital support to the patients and to the paramedicine team, providing guidance, connecting patients with resources, and supplying follow-up care and counsel, coordinating care, you saw that on the slide, in a way that keeps people out of the hospital and in their homes where they're comfortable. You know, we're very proud of what happens in this amazing facility and the other facilities in the medical system. Very proud, and they're essential, but they are actually the default. Where we want to provide care is outside these walls. As has been said before, you have to meet patients where they are. And that's what this program is doing. It's low tech, it's high tech, it's community based. It combines what we can do with our telehealth abilities, and it is a model that puts the patient at the center of the team. We know patients want help, as we heard from the chief, managing their medications. What did you say? A garbage bag of medications. You know how many patients are on 15 different medications? You try that when you have to manage 15 medications a day. They're on 15 medications provided by 6 physicians who too often don't talk to each other, and nobody sits down and says, here's the way you have to do this collectively. And as you saw, it's the #1 need of the patients. And so I thank Dean Natalie Eddington and our School of Pharmacy for leading this part of the effort, being an indispensable resource for patients and for the paramedicine team. Patients want help, as you saw by the data, coordinating their treatment. We are too often fragmented in our provision of health care. So I thank our School of Nursing and our School of Medicine for delivering follow-up care and showing how to better connect providers, not only to the patients, but to each other. Patients need help with transportation. They need help to and from appointments. They need stable housing. And as you saw, they need food. Doesn't matter how brilliant we physicians think we are. If you don't address those needs, nothing happens. It doesn't matter how good our care is. If those needs, those social determinants of health, are not met. So I thank our School of Social Work for making sure that patients are connected to the resources that really underpin wellness. I know Dr. Marcosi hopes to bring legal services. We were just talking about that. And our School of Law certainly wants to be a part of this partnership. We're also assessing the need for oral health services, which I know the Congressman has been a champion of, and how we might bring our School of Dentistry into this program. So this is the way you take a university working closely with our great medical center and put into practice what we preach, what we teach. it teaches our students, the providers of the future, that people need a team-based approach to deal with these incredible obstacles between where they are now and being healthy. So I thank you all so much. I think we're ready for some questions, so I'll ask Dr. Marcosi back to the podium. Thank you.
I want to thank you all for your time, Congressman. We really appreciate the fact that you came here today, particularly on such a big day in D.C. Spending your time with us speaks volumes to your leadership. So I'd like to pause and open the room up for some questions. If there's not any, sir, we're good? Okay. Congressman, if there are none, the Congressman says we're good. Yes, ma'am.
How is this program being funded, and what is the cost of patients?
Yeah, the program is being funded through the HSCRC, through a grant through the HSCRC. It is free for patients, and we expect to be able to carry on this program for about 2 years, and the program is funded for approximately $4 million.
Are the ambulances outfitted with any kind of special equipment, or are they just regular ambulances?
Yeah, we have two different vehicles. We have a vehicle that our community paramedicine team goes out on that is part of the field team that are outfitted with all ALS equipment so that they can actually treat a patient if they arrive on scene, and we have with some who are in extremis. And we also have another vehicle that actually allows us to treat patients at scene and actually release them that has many more capabilities so that we can actually splint somebody or treat treat a laceration or have any other type of minor injuries addressed. So we have two different vehicles as part of the program.
Any idea how many people who are currently underserved will now be served by this kind of program?
Yeah, it's a great question. We have some demographics if you look at your community paramedicine booklet about what we presently have as far as the patients we're treating in West Baltimore. But the question fundamentally is, how do we scale this for the potentially all of Baltimore? And I know the mayor is actually looking at that, and so is Chief Ford. So then we would have to model this out of how we are targeting the high utilizers in West Baltimore, and if we were actually able to scale this would be something that actually could be applied to all the high utilizers of Baltimore, and we'd work with the city's health department to see about how to actually execute that.
Do you have a number?
For West Baltimore, our number, which is a rough number, is approximately 2,000 high utilizers in West Baltimore.
Are the paramedics, are all of them trained to do this, or are there only a certain group, and how many are trained to do this?
Sure. So we have our paramedics have gone through specialized training. There were about 30 of them that went through the training. There are paramedics and nurses who went through that training, and it's a community-based model so that they can go out. It's different than the 911 system where you're actually in an emergency and you have a patient in extremis. This takes time. This takes a different mindset. So when we go to our patients, we're actually in the home for an hour, a half hour to an hour at times, assessing many other things than just simply their health care in the acute event. So we've trained them to the standard for the nation around community paramedics, and that was a week-long training. In addition to that, they're actually shadowing our physicians and nurses, so actually they can get additional training to understand some of the minor, less acute, minor adjustments you can make in your practice as a physician extender.
And just to clarify, you said 2 ambulances that are specially outfitted?
They're not actually ambulances, they're SUVs. There's 2 vehicles that are outfitted a little bit slightly differently. One of them has more robust capabilities because it's able to do treat and release, and then the other is a more outfitted for ALS type response.
Have you started looking at funding options for continuing it past the 2-year mark?
I think some of those discussions are ongoing. I think fundamentally we have to prove that we are successful and we do a good job and our patients are happy with the care, our outcomes are better, and we've saved costs. So I think once we actually are able to validate that, we'll let the data tell the story, and hopefully we'll be able to work with MIMS and the HSCRC to think about next steps.
Well, so for us on that issue, what we've said with our partners at the Rate Commission is defining value is the key to ongoing support. And value in healthcare we describe as a relatively straightforward calculation of the quality of what we do multiplied by the outcomes we get, divided by cost. So those three variables are the variables that we have the responsibility to provide objective metrics of. And so a few years down the road, the commission is going to be asking us to demonstrate that impact. And we understand that, and that's why we're collecting objective data to ensure that we have appropriate conversations at that time.
Yes, ma'am.
So you said that the grant is approximately a two-year grant. So what's the long-term sustainability look like after the grant's completed?
We're hopeful that we demonstrate our value, just as Dr. Santa mentioned. And if we're able to demonstrate our value, then we would have obviously ongoing discussions with the HSCRC and MIMS to think about, and insurers to figure out where the right spot is and where the sweet spot is to actually think about longer-term sustainable funding. Ms. BJ.
Okay, I have my question is coming from our roundtable discussions that Crystal didn't ask. My community, and I have to kind of take off my university hat and go back to my community advocate as a person that runs a clinic in 212 in 16. After the end of your grant, what is the possibility of training community people? And as you know, in our roundtables, many were interested in being a part of your program, but getting training. So now you have more legs out there of healthcare. I have a center that sits right in the middle of 21216, but I have legs of people who will say, you need to go see BJ. And that's what I would like to see for this program. Not only you come to see BJ, but you go here, you go there. Or putting what you do into a clinic like ours that's independent of funding and government funding, that it is run by the community exclusively. What do you see for that possible, what is your vision? Give me a picture.
No question about it, Ms. BJ. So I think once we have proof of concept for what we just described today, the fundamental question is what then? After 30 days, what then? If we have an impact and we're successful for 30 days, who then is the next follow-on to be able to support that patient in their home? Does this program get extended longer? Are there other community resources we could capitalize on and coordinate with to actually support that patient's health in their home? Because as you can see, we actually have an impact for those 30 days, but the fundamental question is, how long does it last? So we're looking at some of those, and I know we've talked to some of you and your colleagues to think about what that looks like after 30 days. And we look forward to having those discussions with community partners about after that and city leaders about what that looks like follow on.
Can you see a vision for something of that nature?
Without question,
Program,
I think it's needed.
Can you take us through the process? Does this all start with a call to 911, or what's the process here?
Sure. So for the minor definitive care now program, the one we just, so there's two different programs. For which program, ma'am?
Well, we go through both then, I guess it's different.
Sure. For minor definitive care now, the 911 call comes in, and there's a team on the street right now in Baltimore that's watching the calls, and as they are ranked lower acuity, they will assign themselves to that call and actually respond in conjunction with the 911 system. Then they'll arrive. There'll be independent assessments of that patient. Could this patient be deemed lower acuity? And then if they are, would you accept care right here so we could treat you and release you so you don't need a definitive transport and evaluation in emergency department? That's the minor definitive care now program. For the other program, which is called transitional health support, you've been admitted to the hospital. You're now in the hospital for congestive heart failure. You have multiple different other potential conditions, and now what happens is you're getting ready to be discharged, and the team says, or the patient says, you know, I've got a lot of things going on. I don't really have stable housing. I don't have a lot of people to take care of me. I still want to go home. And then that team will talk to us and say, you know, mobile integrated healthcare, could you actually support this patient's health at home? And then we enroll the patient in the hospital and go bedside. And then within 1 to 2 business days, we are at their home evaluating that patient to see what their needs are. And for the next 30 days, we're embracing them and then hopefully empowering them so that they better understand where to go next after our 30 days.
So, All right. Well, on behalf, again, of all of the stakeholders who you've heard from today, thank you so much for coming out.